So as per the ABC5 guidelines, visceral crisis, we need to use combination chemotherapy because of quicker and better response rates. However, if you look into CDK4 with endocrine therapy, all the trials have shown, even in visceral mets, better responses, PFS, OS. And right choice trial is a unique trial. It's a phase 2 randomized controlled trial. They have specifically selected this visceral subgroup, ribociclib endocrine versus chemotherapy, and the primary endpoint being progression-free survival. So, well, just to remind about what is visceral crisis and what is the right choice inclusion criteria. Visceral crisis is bilirubin more than 1.5 upper limit of normal range, not Gilbert, not due to obstruction, dyspnea, not due to pleural effusion, cytopenia, bone marrow involvement, and leptomeningeal disease. The right choice inclusion criteria is symptomatic visceral disease and impending visceral compromise due to rapid disease progression and a grossly symptomatic non-visceral disease. So this is the inclusion criteria, and the randomization is 1:1, riboletrozole with OFS versus chemo. Chemo is docetaxel, paclitaxel, cape vinorelbine. These are the combination regimens that we've used, and the primary endpoint is progression-free survival. So these are the baseline characteristics, well matched. What you can note is nearly 90% of them are progesterone receptor positive, and all of them had liver or lung metastasis. And just go to the lowest most, 50% had visceral crisis in this particular study. So if you look into the primary endpoint, the study met its primary endpoint, 1 year versus 2 years, and 1 year increment in progression-free survival. You can just note that the separation of curves happens later on, not that chemotherapy has early separation. Both of them have reasonably similar time for separation. And if you go to the forest plot, if the disease-free interval less than 2 years post-AI, or if you have estrogen receptor status which is less than 50 in that subgroup, it is to the right, and so on. And if you look into visceral crisis, there the hazard ratio is 0.87 and it is crossing unity. So this is the time to subsequent therapy and response rates. So we always thought chemotherapy has better responses, but here they have comparable responses, 65 versus 60. So I think as far as tolerance wise, of course, endocrine therapy will be a winner in case of toxicity as well. So to conclude, right choice is the first and the only phase 2 randomized control trial. We cannot have a phase 3 because of numbers. Who had significant visceral disease, who had rapid deterioration, heavy disease burden, and so on. And the progression-free survival was doubled, 1 versus 2 years with a hazard ratio of 0.5. Response rates are comparable. And even the separation is not early for chemo or for ribo, both are similar. And if you look into the subset of visceral crisis, obvious visceral crisis, ER less than 50% and DFI less than 2 years post-EI, in this subset we need to be a little cautious in this subset before we use CDK4. And of course, safety is better. It is practice changing, and whether can we extrapolate to other CDK4s is a question that we need to address. The second one is ESR1 mutation. So is there any practical applicability of ESR1 mutation is what we will see. Lancet paper phase 3 just now published. ESR1 mutation, so we know estrogen receptor is a steroid receptor, it is cytoplasm. So it has a ligand binding domain to which estrogen binds. That particular receptor can mutate. If that is mutated, then estrogen cannot bind. So AIs act by reducing estrogen levels. So therefore, if you reduce estrogen, if the estrogen receptors are mutated, then AIs became inefficient. So the incidence of ESR1 mutation in a treatment naive patient is around 1%. If a patient has adjuvant AI 2 years back, it is around 4%. If the patient has progressed on AI, then the incidence is 40%, just like PIK3CA. So what are these ESR1 mutations sensitive to? So it has a ligand binding domain mutation. E2 does not bind, therefore it is AI resistant. It is partially sensitive to tamoxifen. It is sensitive to selective estrogen receptor downregulators, and it is sensitive to CDK4, because in the ABEMA mono trial, where they used monotherapy, so it was sensitive to, ESR1 was sensitive to abemaciclib alone. So then post aromatase inhibitor, if you have an ESR1 mutation, there will be other resistance pathways also, like a CDK4 pathway, PIK3CA pathway, mTOR pathway. Therefore, if you have a ESR1 mutation, just changing to fulvestrant doesn't help. You must also use either a CDK4 or a PIK3CA or a mTOR as per the target. And then if you use a lesser dose of SERD, it is less sensitive. If you have a proper dose, it is sensitive. So if it is fulvestrant or SERD resistant, can we use higher dose? It's a matter that we need to look into. So the study design, it's a randomized control trial, HR positive, HER2 negative, 1017 patients were there on AI plus palbociclib. They did blood ESR1. So it's a PCR based method. They did ESR1 in blood at baseline, at 1 month, and at every 2 months. Out of them, 27% was found to have rising ESR1 and 172 were randomized. Remember, these patients had rising ESR1 without radiological progression. And of these ESR1 rising titers, 88 were switched to fulvestrant plus palbo, and the rest 84 were continued on AI plus palbo. So whether changing endocrine backbone and continuing palbociclib, did it help? This is what the study looked into. So this is how the design is, and these are the baseline characteristics. They were well matched, nothing much to look into it. What you can look is visceral mets were there, and the time to inclusion to increase ESR1, all these were well matched. So the study met its primary endpoint. So if I used fulvestrant early, just because of rising ESR1 mutation, did improve progression-free survival. In fact, it doubled progression-free survival. 5.7 in the AI plus palbociclib versus 11.9 in the fulvestrant plus palbociclib. Almost all the subgroup benefited, but bone-only disease was the one that did not show the benefit. So progression-free survival doubled, 1 year versus 6 months. That's the difference. But AI plus placebo, after they progressed, crossed over to fulvestrant plus placebo, and the PFS was 3.5 months. So AI plus placebo followed by fulvestrant placebo, 11.9 versus 9.2. So because what is the important endpoint is this. So just using fulvestrant early, it improved progression-free survival. The better endpoint should have been time to chemotherapy and overall survival. Doing stringent ESR1 mutation would be challenging in a clinically stable patient. This patient is not progressing. PIK3CA should also be tested. We should also test, if PIK3CA is mutant, we should change to alpelisib, not just continue on palbociclib. And I would await overall survival and time to starting chemotherapy as endpoints before I change my practice. Then comes important study. So this is the same extrapolated data of the PADA1 study. So what this study did was, they looked at whether the quantity or the amount of ER and PR expression, does it make difference in clinical outcomes? So we all know the Aldrich score. It is the percentage of cells and also the intensity of staining. And so this is the curve. So if the percentage of ER expression is less than 50, 50 to 80, more than 80, there is a significant difference. Similar thing with progesterone receptor also. The percentage of expression of ER and PR does have implication in terms of progression-free survival, but this is interesting. So the Aldrich score ER, 7 plus or 8 plus does not have difference, whereas if a PR Aldrich score is 8 plus or 7 plus, makes a lot of difference. Therefore, if you see a report with a PR 8 plus or a PR 7 plus, definitely there is a difference. So if you have a strong progesterone receptor of 8 plus, that is the patient that is going to do the best, versus a PR that is 7. So ER7, ER8, no difference, whereas PR7, PR8, there is difference. So these are the, so I'll just read to the conclusion. Multivariate analysis, age, absence of visceral mets or bone-only disease, de novo advanced breast cancer, percentage of progesterone receptor, all marked. and progesterone receptor is the strongest prognostic factor, and IHC less than 50%, we need to use CDK4/6. Even there it benefits, and that's it. And then the last presentation, going on to CDK4/6 inhibitors and thromboembolism. Thromboembolism is seen in up to 1 to 5% in randomized controlled trial with CDK4/6. The real world data report higher incidence. For example, in a Palbo real world, it was up to 9%. And this is the real world study of thromboembolism with abemaciclib. So 5 centers from Boston. It was an observational cohort study, collected demographics, corona score, and primary endpoint during or less than 30 days of abemaciclib. They used, so 364 patients. The incidence was 7.4% thromboembolism. 2/3 had venous thromboembolism and 1/3 had arterial. So venous means it is pulmonary embolism, arterial is CVA. And those patients who had embolism lived shorter, 25 versus 9 months. So this is the curves. So to conclude, the first real world evidence for abemaciclib has 7.4% thromboembolism, almost 2 times than reported in clinical trial, and they have higher mortality. And because this drug we are using in adjuvant setting, should we use thromboprophylaxis with aspirin or anticoagulants, we need to see. And checking corona score is not prognostic. And Palbo and Ribo also have similar incidence of thromboembolism, and there is a warning for thromboembolism and interstitial lung disease for CDK4 inhibitors. Thank you.